Good afternoon, good morning, everyone. Welcome to this presentation. This is for purposes of introducing myself, and then I'll just switch off the camera. Yeah. So we are implementing the research, doing a research on wasting to improve screening and identification of children who are wasted, and to ensure that they are treated on time. And this is happening in Turkana County, in 3 sub-counties: Turkana East, Turkana South, and Aro. Can go to the next slide. So I will present on the background, study objectives, and the theory of change. And then Medic will take over for the workflow demos. Next slide, please. So Turkana is located on a northern western part of Kenya, with an estimated 77,000 square kilometers of mass, that is inclusive of Lake Turkana. When you're looking at the land mass, is about 71,000 square kilometers. And this you can equate it to 3 countries, Djibouti, Eritrea, and Rwanda put together. So it is a vast landmass, and it is faced with different challenges. One being very high GAM rates, or GAM prevalence, that is the Global Acute Malnutrition. In 2024, after the SMART survey, we had a GAM rate of 21.8, which is down from 26.4. So those are way above the WHO standards of 15%. However, when you look at the national level, our prevalence is at 4.9%, just slightly below the World Health Assembly targets of 5%, with that difference, you can see there's obscurity in terms of at the national level and at the subnational level. So this, with other challenges such as coverage, we have around 236 facilities that provide imam services out of 305 functional facilities within Turkana County, which cannot essentially support all children who have wasting. And some of the issues that affect coverage are economic access, where we have limited transport to facilities, and also the use of facilities is very minimal. Another issue that affects coverage is the physical access. I've mentioned about the landmass vis-a-vis the facilities that are available in Turkana County. So with this, people have to walk long distances for them to ensure that they are able to access facilities. And also the unfavorable terrain within Turkana County. Insecurity is very high in Turkana County, especially in the southern area where I have mentioned. That is Turkana South and Aro, and Turkana East, which are border sub-counties. And part of the issues that cause insecurity is cattle rustling, which is very prominent in this part of the world. We also have poor road networks within Turkana County that affect the physical access of the facilities. For the outreach barriers, we have around 498 outreaches, total mapped outreaches. However, the only functional ones currently are 36 functional outreaches. So despite mapping, those supported currently only 36. So we can still see the gap there. For community barriers, there's limited knowledge of the prevention and causes of acute malnutrition, and also delayed health-seeking behaviors. So when you look at coverage in Turkana County, there are some areas where this is a barrier, some areas this is a booster, where some are very knowledgeable about causes of malnutrition, and they would seek healthcare services. But in some areas, this is still a barrier. Caregiver challenges. We have high maternal and caregiver workload. Alcoholism is one of the issues that also affect, which contributes to the high gum rates of prevalence, and instrumental parentification, where you get younger children taking care of other younger children within the home state. We have healthcare challenges. We have shortage of staff, CHPs are overburdened, and limited capacity, which then now brings us to why the part of CHV of being overburdened is one also of the reasons why we are here today. Another issue contributing to this particular study, and we'll see why family mark is very important to this study, is that it has a potential of scalability. When we are screening for malnutrition, we have the different ways or anthropometric measures that we use. We have the weight, height, and also the mark screening that we do. For weight and height, that give us weight for height Z-scores, we'll need taking of the weight and the height, which needs more people compared to mark screening. And we wanted then this to be owned by the caregivers, hence the family mark screening tool, and hence its scalability, that we can train more people to ensure that every child is reached and no one is left behind. To the next slide, please. So the study objectives, we have two. One, to implement the community package of intervention for wasting detection and follow-up. And two, to document the reach, adoption, and implementation challenges of CHPs on the community package. Next slide. So this is the theory of change. And we have the normal continuum of care, where we do screening and referral, and then if the children are admitted successfully into programming and for treatment, they're treated with the necessary products. However, for this particular research, we intend to include one, we intend to ensure that there's digitization of the ICHIS. We intend to ensure that we have better screening so that we have more children admitted into the program. We realize that MWAC does not cover all children, or all children do not successfully get admitted or meet the admission criteria into the program using MWAC. So WAS is the best and easiest to use in the community, because you only need a weighing scale to ensure that we take one of the other anthropometric measures. Age is usually gotten from the mother-child booklet. Another thing we want to include in this research is that there's reminders, proper interaction between caregivers, CHAs and CHPs, that once a CHP takes long before going to a household, they're reminded. Another one is that once a child gets to 6 months, a CHP is reminded that there's need for training of the caregiver on how to screen the 6-month-old child. Another one is linking CHPs and CHAs for monitoring and supervision. This is a huge gap, considering one, the vastness of Turkana County, and also limited staff to do the supervision. So we want to ensure work is reduced in terms of physical working in terms of supervision, that there's reminders and no one falls through the cracks. So what is the expected output? One is that more families will do screening. There'll be acceptance of family work in the community. And after the screening, caregivers are able to go to the health facility, to the nearest health facility. Despite the fact that they might not be admitted into the program, they will get other services, such as supplementation. And if there's any other ailment, then they'll get treated. Then another output that we'll have is that more CHVs will follow up, and they'll reduce barriers of treatment and adherence. Outcome, we expect that more children are assessed, and not wasted and receive other relevant health services at the health facility. And more children are confirmed wasted and timely enrollment or for treatment, thus increasing the treatment initiation. And more unrecovered defaulters are enrolled and more timely and adhere to treatment. So thus we expect an increased treatment coverage at the end of the program. Next slide. I think this is Medic.
Yeah, Ben. So as Ben takes over the mic, let's continue with the introduction in our call chat. Tell us your name, your role and the organization you work for, and the specific implementation you're involved in. So, Ben.
Thank you, Anthony. Good afternoon, good morning, everyone, wherever you are. I trust you're all well. My name is Ben Kiarie. I'm an app developer at Medic, and I'm the one supporting the R-Switch implementation. So I'm going to go ahead and do a demo of the scenarios that we see on the screen just to make what Noelyne has described, to help everyone visualize what Noelyne has described. All right, Anthony, let me know if you can see my screen. Thank you. So, as Noelyne has described, one of the key components of this study are the caregivers. So what we have here on the left is a login as a CHP. And here I have used Anthony as my CHP. So, community health promoter, that's what they're called in Kenya, but that's equivalent to a community health worker. So here Anthony is logged in and he has visited my household. So we can see under his area, he has Ben Kiarie household. So to administer the service of enrolling me to the R-Switch project, that is a form that is available to the caregivers. In this household, we have one person called Ben Kiarie and a baby. So the caregivers are anyone above the age of 15, if I am correct. And that form is available here in the action button. So as a CHP, Anthony clicks this button and he can see the different forms to perform different services. And the one we are interested in is the nutrition enrollment form. So once they click that, we get to see the form. So it says you can sign up to receive text messages if you can read and write in English, Swahili, or Turkana, or if you have a trusted person who can help you read and write. So this was very intentional to be cognizant of the realities in Turkana, that we try to offer different languages, and at the same time, for those who have low literacy levels, maybe they have someone in the household who can help them read the messages. So the next here we have it's a consent question where Anthony would ask the caregiver, would Ben like to receive free text messages from your CHP about nutrition for children under your care? Once the caregiver gives their consent, there's further clarification from the CHP to explain to the caregiver. Please be aware that text messages are generally secure, but family and friends will be able to see messages you send or receive if they have access to your phone. Please ensure you protect your messages as you see necessary. Here we have a note explaining that we currently only support Safaricom because, as Noelyne explained, Turkana is one of the hard to reach areas and connectivity on other telcos is limited. So for now, we support Safaricom only. Then the next question is a chance for the caregiver to confirm that this is their number, because we are pulling the number from the contact in each. They can say yes, and then we shall use that, or they can say no, and then they will give us the number that they want to receive the messages on. So in this case, we'll say yes. And here we mentioned earlier that we support the 3 languages. So we'll go ahead and select English and click next. So this is the form summary page just for the CHP to note that everything is in order. In particular, we only want to confirm the number and the language that the caregiver has selected. So I'm going to go ahead and submit and we'll see what happens. So as a CHP, they have submitted the form and they have synced. So now if I open my phone here, we can see these are the messages that have come in on the right. It says, "Hello, Ben Kiarie. This is Anthony, your CHP. You will be receiving SMSs on good nutrition for your child and remind you to measure the nutrition status of your child. I am here for you." So this first one is a welcome message, just to let the caregiver know that they have enrolled. Then the next one is what is called an FMOC prompt. So it's an opportunity while the CHP is there with the caregiver, possibly train them or retrain them on how to do an FMOC reading for their child. So in this case, they can say 1 for yes or 2 for no. So I'm going to say 2 so that I can demonstrate the next thing that the caregiver can do. So if I say 2, let's give it a second for the messages to go around the world and back to us. So it says, "Thank you. Please take the FMOC reading of your child under your care every 2 weeks. Thank you for taking FMOC for your children." So in this case, we had said no. So let's say since now the caregiver has been trained, I being the caregiver, I have been trained by Anthony on how to take FMOC. I can initiate taking an FMOC. I don't have to wait for the system to prompt me. And in order to do that, I send the letter F to the same shortcode. And then we get back the question, would you like to submit an FMOC reading for baby 6 months? So if we go back to the left here, we can see the baby that was there was called 6 months. And then I can say now yes. If I reply with 1, that indicates I would like to conduct an FMOC reading. Okay, so we get a question. Submit the reading for baby 6 months. Reply with 1 for red, 2 for yellow, 3 for green, and 4 for not available. So each of these are the different malnutrition levels, I would say that, but that is not technically a nutrition term. So in this case, I'm going to select red because when it is red, that is a danger sign. And what is going to happen is a message is going to go to my CHP to let them know that this is a case that needs follow-up. So we're going to say red and we'll receive something back. Okay, it says, repeat the MWAC measure to be sure you are correct. If you measure red twice, your child has severe malnutrition and can quickly become ill. You should go to the health center immediately. Thank you for taking FMWAC for your children. So at this point, I'm going to pause and ask Anthony, my CHP, since I submitted red, did you receive a message on your end?
Yes, so I've received a message saying, "Hello, Anthony, Ben Kiarie has submitted FMAC reading for baby 6 months. Please follow up within 24 hours. To confirm, baby 6 months have been taken to the health facility."
Okay, thank you. So what I've demonstrated there is the flow where we are giving CHPs, the R switch is giving the research study is trying to see the interaction between the CHP and the caregivers via ICHIS to improve malnutrition of the children, of wasted children. So I'll pause there if anyone has a question before I go on to demonstrate the second thing on our agenda.
Yes, Diana.
I have a question. So in this interaction with this short code, is there a way that a user can ask for help? Like, I don't know, what should I send? My child is looking pretty bad, and I want to send something, and I forgot.
That's a very good question, Diana, because that brings on me to my next part of the demo.
I didn't even know.
I had foreseen this, but anyway, it's a good question because we don't want to be so limited in a structured way. So we also are allowing CHPs and caregivers to communicate. So as a caregiver, I can communicate and say, "Hi, Anthony, I need help." So if I send that, it comes here to the CHP, but they need to sync so that they can get that message. So if I sync, and I can get it here. So they can ask the question, and now from here, the CHP can reply to the caregiver. Hi, Ben, how can I help?
So Anthony did not receive this message on his phone, like the other message he received.
Yes, no, they did not, because the challenge was a CHP is supporting different caregivers. So this was the best way to have them know who they are talking to. Okay, so it has been forwarded. If we give it a couple of more seconds, we should get the message. There we go. So that's one way of the CHPs and caregivers being able to talk about malnutrition and other health-related issues. I hope that answers your question, Diana.
Yes, it does. Thank you very much.
Thank you. Okay. And then I'll stop there and pause for a second if someone has a question before I go to the final part of the demo.
Ben, quick one. How frequently do the messages go out to, let's say, under 1 children? Like just to remind them to take the F mark?
It will be scheduled to go out every 2 weeks.
All right.
Yeah. So
Thank
every 2 weeks is the system prompted reminder, like, would you like to take an F mark? But the ability to send F allows this caregiver to do an F mark at any point they see fit. So we have those two scenarios.
All right. I've seen a question from Dr. Tomo Amolo. I'm not sure if you want to voice that. I've seen Diana responding to that. Dr. Tom?
Good afternoon, everyone. Thanks. I think Diana has already responded because I did note that Ben did the synchronization manually. So I just wanted to understand whether it is automatical synchronization to make the communication easy, or the CHP or the caregiver has to do it manually, because that then would bring complications in the event that they forget to synchronize. Then there's probably delay, but I think that has been responded to. Thanks.
Okay. All right. Thanks, Dr. Tom. Ben, do you want to add anything more?
No, I think that captures
the other question now that you did mention that
talk to Nani.
Hello.
Noelyne, I can mute you. Please, Dr. Tom, go on.
Does it then mean that you have to be always connected to the internet for this synchronization to happen. So how easy is it for the caregivers to always be having data access and always online from your experience?
That's a good question. I'll answer, and then if anyone from IRC wants to contribute, they can chime in. So on the caregiver side, which is on my screen is the right side, this is the traditional or messages on your phone, which does not require internet. So the caregivers can send their messages without internet, without requiring internet. But on the left side, this is now the CHP, so the community health worker. So to your question, if they send a message to the caregiver, do they need internet for that message to be received by the caregiver? Not necessarily, because through IRC and other stakeholders, ICHIS and the government, there is whitelisting that allows the CHPs to be able to sync without requiring internet. As long as their data on their phone is on, they are able to sync their reports and their messages. So they don't need technically internet connection, they just need to turn on their data. I hope that answers the question.
Yes, and just to add is that we are also paying for the SMSs. So the caregivers are not using their money. It's free on their end because we are paying for that. Thanks.
All right. Thanks, Janet, Tom, and Ben. So Ben, can you
Yes.
complete the remaining section in the next 1 minute?
Yes. So I'm going to now send a message as a CHA because Noelyne mentioned about the supervisors being part of this process. So I'm going to log in as a CHA. So a CHA is a supervisor. And one of the things they shall be doing is what Noelyne described as action days. So they want everyone in the community to come together for sensitization about nutrition, malnutrition, and that good stuff. So here I'm now logged in as a supervisor, a CHA. I'll be able to see the different areas of my CHPs here. For this instance, I only have Anthony. So I can then create a CHA action day. And I can say we have an action day for WAS screening, which is what Noelyne described earlier. I can say it's tomorrow and I click submit. So if you give it a few seconds, we can see the message that comes on my end as a caregiver. It says, hello, Ben Kiarie. This is Anthony, your CHP. There is an action day on this day. I will be visiting your household during that time. And at the same time, a similar message has gone to the CHP. So I will let Anthony read his message.
Yeah, the message says, hello, Anthony. There is an action day on 14th of 11. Please mobilize and be available for words rollout during this period. Yeah, thank you.
Thank you. And that concludes the demo. There's a lot more, but this is what we could share for now. And please stay tuned for more on this research project as it rolls out. Thank you. Over to you, Anthony.
Thanks. Yeah, great demo, Ben, and some great inputs from Janet, Tom, Noelyne, and the team. Noelyne, do you want to continue? I think we can move to the next slide, Diana.
Yes.
Yeah.
So before we got here, we had a user acceptance testing where a medic came to the ground to test the two-way messaging. And we also had a training for the trainers of trainers who are the focal persons, the CHS focal persons. We had nutritionists who are trained at the sub-county level and also the HRIOs. So from that, we got feedback on how to improve the product. One was on tracking of CHPs if they've done the family mark training, because you expect that all caregivers have been trained by CHPs. and also then how follow-up can be done. For the caregivers, one of the feedback was that we need to have a better way on how to track the caregivers, because each month each is reboots and it refreshes, so that data is lost. Another non-tracking is to include family mark tips in the commodity count form, which I believe that has been done. We had a session today with Medic, so that has been included. Another inclusion was on the retraining. The first interaction and training we did with the caregivers was to train them on family mark exhaustively, that all caregivers are trained on family mark. And one of the forms where we are doing assessments in each is asking the CHP to observe how the caregiver is taking the mark measurement. And if then the CHP notices the caregiver is taking a wrong measurement, there's a prompt for them to train again. So this is still a service being rendered. Yes, they trained the first time. So is there a way to capture this as retraining? So that has already been sorted out. That was part of the discussion today with Medic. Another inclusion is providing a field where CHA can type the name of the venue for Action Day. So for the Action Day, the major activity that we'll be doing at the Action Day is on taking the weight so that we can calculate was and referral is done. However, when the CHA is sending out, currently when the CHA is sending out that message to the CHPs, one, it is sent out collectively. A CHA can have 10 CHPs, each has their own village, and they might have different days of preference where they would want to have their Action Day. So request is to have it personalized, that the CHA can write, Anthony, allow me to take you as a CHP that today, Anthony, will be having an Action Day on the 14th at this and this time. So one is to personalize the message to the CHP, include the venue, and also the time and date. Date is already there, so the other three to be included. Then another inclusion is to add an F for family mark as a means to initiate child measurement. Should be included in the prompt message loop. For this, Ben has already mentioned that there'll be prompts for children to be assessed using the family mark. However, if that message takes time before the caregiver takes a measurement and goes through the process and submits it, and then another message comes in maybe for an Action Day, then that process is interfered with. So for the caregiver, if the caregiver wants to take the family mark measurement, they're able to send an F. And I think Ben has worked on this, and this is active. That the caregiver, if this message came in on the 13th to take the family mark measurement, but probably the mother was engaged in something else, and it took a day or three, and she received an Action Day message, then she can send an F so that she's able to send a family mark message before going for the Action Day. Another inclusion is personalize the message to a particular child by using their name instead of the age bracket string. So this is to ensure in a family, in a household, we can have two children. A caregiver can have two children under 5 years. So how would the caregiver know that it is this particular reading is for child A or child B? So it's to personalize the message, that this message is for Noelyne, or this message is for Anthony. So then we can easily track the child within the system. To the next slide, please. Yes. Janet, would you? Take this, or I can go through with it?
Go ahead.
Okay. So acknowledgements, this is a special thank you to the following. This research is not entirely done by IRC. We are the implementing partners. Gates Foundation is our donor, and we are grateful for the opportunity to have had received this grant. UNICEF also for giving us the technical support, and also subgranting this grant to IRC to implement. The Division of Community Health at the national level and also at the county level has been very instrumental in ensuring that, one, we're able to test the two-way messaging and ensure that we're able to test it right now in Turkana County. I believe Ben is working on it, and by Friday it will be ready for us to enroll the caregivers in the larger Turkana South. The Division of Nutrition at the national level and the county level have also been very instrumental in terms of goodwill, and also ensuring that we have enough resources to reach the different areas within the sub-counties. The County Health of Department of Health in Turkana County, IFPRI, and Kenyatta University are our PIs. IFPRI is the global, and Kenyatta University at the country level. So also they've been very instrumental in, one, getting the baseline survey, and we involve them even in the midline and endline surveys. And also thank you to Medic for being very open to our suggestions and working very promptly to ensure that ICHIS works for the research. Thank you very much. Over to you, Andrew.
All right, thanks, Noelyne. Francis, I'm not sure if you have a few seconds just to add your thoughts.
I guess that's me. Eh?
Yeah, 30 seconds.
Okay, yeah. My 30 seconds with a question. And I'll start with the question, when are we now going live in terms of the messages deploying? Given that I know we are planned for a midline latest February, and we need at least 2 months, full months of implementation so that we can be able to pick something from the midline. However, just want to commend everyone, as Noelyne has indicated, for the support throughout this process. I must say it has been a journey, and thanks to the Medic who have been gracious enough to accommodate all our wild thoughts, and which has culminated to this good piece of work, which will ultimately lead to strengthening of the community health units, and also the deployment of the ECHIS, and hopefully the country can borrow on the integrated SMS platform to the other areas. So thanks so much, and we are looking forward to continuing this collaboration until we come to the end of this research. Thank you.
All right, thanks, Francis. Ben, would you like just to share a 15 seconds update on when are we going live?
Yes, Anthony. Everything is going on to meet the date of tomorrow, because there's planned activity next week.
All right. Thanks, Ben, and thanks everyone for the awesome presentation and demo. We are looking forward to hearing more updates of the findings, and we wish you all